Mr. Miller, to both of you, last time Congress mandated comprehensive reform Medicare payments was in 1997 with the Balanced Budget Act. We are considering changes and reforms to extend the life of Medicare similar or greater in magnitude to those reforms. Many believe Congress took reform too far in 97 and consequently gave back some of those reforms in 1999 and beyond. So, broader question at the beginning, how does Congress aggressively pursue reform that extends the life of Medicare without repeating some of the mistakes of the past? Mr. Blum?
So a couple of points. I mean, one, I think Congress should recognize that there was many changes made to the Affordable Care Act to reduce spending on post-acute care savings. Of the Medicare savings that were included in the Affordable Care Act, home health, skilled nursing, all of the different payment systems did experience payment reductions. I believe that over the long term, what we need to do is to shift the system, as Mark suggested, to ensure more accountable total care models. And I think what Congress can do is to provide clear direction, clear roadmaps for how that system should change over time. The President's budget set a goal or a target for post-acute care bundling by 2017. Really, our intent there is to send a clear signal and a clear direction how the health delivery system should move. We also feel in the interim that we have to take other payment steps in the short term to ensure that our payments are more accurate relative to the cost of the care. The President's budget has several ideas how to achieve that, but I think the most important thing long term is to ensure that we can achieve more of a site-neutral payment where we align the incentives of post-acute care providers.
Mr. Miller?
The things I would say is you want to probably move in steps. So when you're taking rates down because that they're overstated, you move in a series of steps over time. As I said in my opening comments, you try and also get the underlying payment system to follow the payments to the complex patients so that you're not taxing the facilities that are going after the most difficult payments. And then I agree with a comment over here that if you can get to payment systems that are more population or episode-based, you give the provider flexibility and allow them to move the resources around as long as you've protected the risk to the program.
Mr. Miller, you referenced MedPAC's work on neutral payments in your original testimony. We have a real interest in that area. Why have you focused on that policy area? How important is it that we pursue that?
I think the Commission believes it's very important. This has been a problem that's been around for 15, 20, 30 years. When I started, people talked about it, and it's still. I think the fundamental problem is twofold. One is at the seams of these payment systems, you create odd incentives. So if one payment system pays more than another for the same service or the same patient, then people begin to behave in ways that are not clinically driven and instead driven to maximize payments. And you get behaviors that affect the beneficiaries out of pocket and behaviors that affect the program expenditures. But you also stimulate changes in the environment. We think that some of this is ambulatory care, 1 second off point. We think that payment has stimulated purchase of physician practices, for example. One quick wrap up. The Commission has talked about site-neutral payments in the ambulatory setting, with more of that coming out in our report today. Here, we're looking at the site-neutral payment between hospitals and long-term care hospitals, and just beginning to think about some of the relationship between the inpatient rehab facility and skilled nursing facilities.
Tell us about the unified assessment tool that you referenced in your. How does that work? How far along is it? What kind of insight does it provide us as we're looking at reimbursement issues? And
I may throw this over to John because he'll probably know more about what the current state of play is. But the fundamental situation is and particularly in post-acute care, the two things you're generally looking for is the diagnosis and condition of the patient. But beyond that, what you want is their functional status, their ability to walk, their ability to do things like that. What we have are these instruments in different settings that measure that different ways, and in some settings they don't have a consistent instrument. And that means you can't compare the patients across setting and figure out whether the payments and the outcomes are calibrated. There was a demonstration done by CMS, and we had called for this a long time back, that an instrument needed to be created, and CMS developed one and did a demonstration, and my view of it is that demonstration is pretty promising in saying that you can measure patients consistently across a lot of these categories. Its status, et cetera, I would hand off.
What is the status, Mr. Blum?
The status is that we have spent the past several years demonstrating, working with providers, the CARE tool. We feel confident that the CARE tool shows promise and how we push it out to all of our different payment systems. Through our Center for Innovation projects, we intend to use the CARE tool to some degree to assess how patients fare once you integrate the payments. So we are at a point where we feel confident within the CARE tool that it still needs refinement, but we believe that it holds tremendous promise, as Mark said, to assess patients across different care settings, and CMS plans to deploy it for the first time through our payment innovation.
Would you, by letter, share with us how the tool works, the methodology
Absolutely.
for arriving at it and the status of it? That'd be very helpful.
Absolutely.
One of my concerns, you referenced early on that we don't have criteria in the SNFs and the rehab hospitals, and we're getting to bundling payments. But my impression has been that CMS has had the requirement and direction from Congress for many years to develop these criteria and to move toward bundled payments. I guess my overall question is, why is it taking so long?
Well, I think, to me, there are several challenges. Number one is that the post-acute care marketplace has been established over time very differently across the country. Different parts of the country have different mix of services. So defining one unifying definition to what an episode is challenging given the current marketplace. The other challenge is who gets the money. Does the hospital get the money and then decide where the patient goes and pays the provider versus having the locus of payment be more with the post-acute care provider system? Those are very important questions that we are testing. Through our current work on bundled payments, we are, for the first time, I think, really establishing common payment episodes, testing 4 different models, and there really is no off-the-shelf model that we know of that CMS can simply put to our payment systems. We are working very collaboratively with the hospital industry, post-acute care industry, to define those episodes. And I think for the first time, the agency is building the infrastructure, not for just micro tests, but for large-scale transformation to move to a more integrated post-acute care system. So it is challenging, to be sure, but we feel confident that for the first time, the industry, the healthcare delivery system, is building the platform to develop a very extensive bundled payment system.
Okay. Thank you, Mr. Blum. Before I recognize Mr. McDermott, at some point, Mr. Miller, during the hearing, I hope you'll address the President's budget is focused on market basket updates. MedPAC has included rebasing as part of your recommendation as well. At some point, I'd like to hear why. Mr. McDermott's recognized.
Get that, make sure that you come back to me. Okay.